delighted to welcome my friend Ashish Jha to be our keynote speaker and kick this off. Ashish is a professor of health policy at the Harvard Chan School of Public Health and the director of the Harvard Global Health Institute, but he is about to leave and become the dean of the School of Public Health at Brown. Are you still going to practice when you're at Brown? Are you still going to be an internist?
That's the hope, if they'll have me.
Okay, that's great. So Ashish is one of the most compassionate and reasonable, both at the same time, people I know and voices in the world of public health. And he's also someone who's really open to varying perspectives and collaborations. He's highly publicly engaged. You've probably seen him on television. He has a wonderful blog called The Nouns of Evidence. He has an excellent Twitter feed. He does many media interviews, most recently one in Hindi, which I think is very impressive. I tried to do one in another language. That's very difficult. His interests span the globe, and he's an equally thoughtful commentator and scholar of U.S. health policy and global health policy. He and I recently worked together on a project looking at social determinants of health, and I know he was supposed to be spending this semester on sabbatical, traveling the world, learning about the nuances of differences in healthcare systems. Sadly, for all of us, traveling around the world isn't happening for anybody, but we are very fortunate to have Ashish's wisdom and guidance as we deal with this truly horrifying pandemic, and I am delighted to welcome him to the webinar. So congratulations on your new appointment, Ashish.
Thank you, Sherri.
Our association is made up of researchers inside and outside academia who work on housing policy, education policy, health policy, environmental policy, and so on, and also around the management of public policy. And so I want to ask you some questions about how you see researchers studying both of these areas in the wake of COVID-19. I see lots of names on the call of people who've been doing that kind of work already. And what we'll do is I'll ask you some questions and then we'll take some questions from the audience. There are about 100 people just on the call already. So let's start with public health policy and some granular questions about COVID-19. Leaving the clinical science piece of it aside, because we don't have clinical scientists, what kind of social science questions would you most like to know the answers to right now as you think about how we're going to deal with this crisis going forward?
Great. So Sherri, thank you for inviting me and for everybody for having me on. If it's okay, I'm going to try to answer that question by laying out kind of where I think the pandemic is and the clinical science, and then we won't talk about it much, versus the everything else. And in many ways, we're about 4 or 5 months into this pandemic, and I often use the analogy of we're kind of in the top of the third inning of a baseball game, meaning we have a long way to go. The clinical science stuff has been phenomenal, actually. Like in 2.5, 3 months, 4 months, what we have figured out about this virus is extraordinary. And almost all of the challenges that we face, in my mind, are not about biology, are not about clinical medicine. There are important clinical medicine issues that we do face, and we're not going to talk about them, but they are important. But almost all of the things that have hindered our response fall, in my mind, outside of clinical practice. Meaning, if we were sitting here in mid-January and we knew this pandemic was coming, I don't think the clinical stuff would have been, and the scientific stuff would have moved as fast and effectively as it has. But I also just don't think everything else would have gone as badly as it has. So that to me is such an interesting phenomenon. And let me make one last point about this, which is there is pretty much like consensus on what we should be doing as a country, how to get this virus under control, how to get a good chunk of our lives back. There's small disagreements among scholars on some of those issues, but they're really at the margin. So where have we gotten really stuck? There has been a whole set of challenges around communication where I feel like people who think about crisis communication around public health, we have to learn how to do this much, much better. And there's an entire kind of research agenda around what does communication in times of crisis look like and from leadership. There's been a massive set of negative effects on our healthcare system. It's remarkable that in the middle of the pandemic, most hospitals are financially getting crushed because the health system just had not planned for this in any kind of a substantial way. And the things I think about are like, what exactly just happened to everybody in America who didn't have COVID over the last few months, who rely on the health system? And there's a set of policy questions that come around that. One of the areas where people are very, very worried is the decimating effect of this pandemic on primary care. And so from a health policy point of view and a payment policy, we have to totally rethink how we are paying for our care in the moments of crisis like this. Obviously, there have been very large effects on minority and poor populations. And I think there's an entire research agenda around sorting that out. And there are two parts of that. One is, why did we do that? Why didn't we see it coming? We should have. And then, of course, now that it's happened, how do we prevent that from propagating all through the rest of the pandemic? And let me make one last big picture comment, and then I'm happy to go wherever you want, Sherri. The last big picture point is one of the major sort of stress points in the pandemic response in the US has been the issues of what's federal, what's state. And in public health, there's always been a deal, as I understood it, which was that states led on public health and the federal government provided technical support, financial support, coordination, and played a very large role helping states. And the federal government has largely been absent. They're sort of, at my most sort of cynical moments, I just say the federal government decided to take this pandemic off. And so what does this do with that relationship? If under a crisis situation, one of the two partners walks away, how do states manage this? And how do we come up with new approaches for state-to-state partnerships and collaboration in the context of a federal government that's dysfunctional? Those are, to me, the big things that are really hindering our ability to make progress. The public health and the clinical science stuff is actually going pretty well.
That's really interesting, and I'm struck. Actually, would you like to just amplify the point you made at the beginning, that if we had caught this in January, the clinical stuff would not be going as well, but we'd be doing better? It just was an interesting point.
Yeah, I mean, if we were having this call in January, and let's say, in January it wasn't clear whether it was going to truly become a pandemic, but let's say we knew it was going to end up being a pandemic and it was going to end up being bad. What I would have said is, we've got to sequence the genome. We've got to really understand the virus. We've got to start coming up with therapies. Vaccines take several years. Even clinical manifestations take us a long time to learn about. So the clinical and the scientific aspects of this are going to take us several years. But we know how to deal with outbreaks and disease outbreaks and respiratory viruses that cause outbreaks like this. And what we're going to need to do is build up a great testing program. We're going to communicate effectively to people. We're going to need to, and you could have laid out the public health plan. And I would have guessed, not actually would I have guessed, in late January, I wrote a piece for Health Affairs, shows how prescient I am, basically saying America was going to be largely left unscathed from this outbreak. You may at this point be asking and wondering, why have you guys invited me, given my ability to predict the future? And I got it completely wrong, because I really thought we were going to have an effective federal response from the CDC, which was the best public health agency in the world. And so I expected that stuff to just go swimmingly well. And then I just thought the science and stuff would take a while to catch up.
Interesting. So I was really struck. I've been reading a little bit about the 1918 influenza pandemic. And one of the things that's striking to me is that the public health response is pretty much the same as it was then. We do masks, we lock down, we recommend social distancing, but so much of our world has changed since then. Do you see any opportunities? Are there things that researchers or policymakers should be doing differently than we did in 1918, because we do have this technological armamentarium?
Yeah, so one thing we have is we have much better scientific basis for a lot of the stuff we're doing. So we know, for instance, that the social distancing policies that were put in really were pretty effective. You can see it in the data. We have data on mobility, right? So we can look and say, oh yeah, there was an 80% reduction in mobility in the days. And actually one of the interesting things that we're learning, and there is a question about the impact of policy, is that most of the drops in mobility happened before governors actually put in shelter in place. Because it turns out
some of the people on our call did some of that work. So that's very cool.
Fabulous. No, and that's really important, because it says that while policy is important, sometimes policy leads, sometimes policy lags, and people don't necessarily need their governor to say, don't go out and get sick. People don't want to go out and get sick. And so if there's enough information out there for people to assess that going out to a restaurant is going to be dangerous, even if that restaurant is open, a lot of people will choose not to. The flip side of it is when governors come in and say, okay, we're opening up the state, people can go back to restaurants, don't assume people are going to automatically go back to restaurants. right? Because people are going to have to feel confident about going back to restaurants. So that's the other part of this. So I think that data has been very, very helpful in sorting out what policies actually do work and how much do they work. Our modeling around the disease has been, there's been a lot of pushback on a lot of the models and stuff, but the truth is it's actually been quite good. So the level of accuracy of the models overall has been, I think, terrific. And unfortunately, because they predicted a lot of deaths and we've got a lot of deaths. You would think the whole point of that is not just be able to document and predict, but then hopefully to change behavior as a result of it. And that's the part where we have not done much better than the 1918 flu pandemic. Obviously, the science is moving much, much faster. But the bottom line is that, the flu pandemic of 1918 killed 30 to 50 million people. This shouldn't be that bad. We should be able to do much, much better, partly because we know more, partly because we're acting more effectively.
So one of the questions that's been a focus in the social science literature about COVID, that there's this burgeoning literature, is about the emergence of disparities in the US. And I think I found that there was an article in The Lancet using the NHS data that I thought was very, very interesting, showing the same disparities emerging there. And you and I just finished up this project on socioeconomic disparities in health. So how do you think about the emergence of these disparities? To what extent do you think they have anything to do with the healthcare system, or what else do you think we ought to be looking at? Because I think it's a fascinating question. Where did these disparities come from?
Yeah, obviously it's multifaceted. And I always sort of think about two different phenomena that are related but not the same that we've seen. One is racial and ethnic minorities. Overall in the country, I say the data is best for African Americans, but in many communities, Latinos as well. What we see is much higher rates of getting infected, and there's a set of social phenomena that drive that. And then, even given a certain level of infection, much higher rates of mortality, which I think is got a related but separate set of issues to deal with. And on higher rates of infection, in my mind, that's very little to do with the healthcare system and a lot to do with where people live, the kinds of jobs people have, how they get to work. All of that, I think, has been a really major driver of all that. And who we call essential workers and who comprises essential workers, and of course, neighborhoods. There's a set of factors that really have driven much higher rates of infection. To me, as puzzling and in some ways almost more bothersome, I don't know if it's more bothersome, but also very bothersome, is the fact that given a certain level of infection, you've seen much higher mortality rates. And that makes me start wondering. So I think the best evidence we have, and it's really weak evidence, but we need to sort this out, is we know that levels of testing in African-American communities are lower. At least there's some data on that. And so you can imagine, therefore, that people are getting tested and identified later in the disease. That could be part of it. There's a long literature, a lot of the work we've done, that healthcare providers that disproportionately take care of minority patients tend to be of poorer quality, have fewer resources. And there's a set of policy things that lead into that and a set of policy implications that come out of that work. And so if African Americans, for instance, are ending up at hospitals that are poorer quality, then worse outcomes is explained at least in part by that. So this is a hugely important phenomenon. What I've been frustrated by is how much we were caught off guard. We didn't see it coming because nobody was collecting data in a systematic way. Now that we have better data, we see this. And of course, the single biggest issue in my mind right now is that we're not anywhere near done with this pandemic. So how do we make sure that over the next 6 innings of the baseball game, in my analogy, we don't continue repeating the same set of mistakes?
Do you have any idea what we might want to know to avoid repeating those mistakes? What are some things, if you could just wave a magic wand and know something, what are the things you might want to know about how we avoid that?
So I want to understand transmission issues better across communities. And this now gets a little bit into clinical medicine, but it actually it's pretty sociological as well about, there's a lot we're still learning about inter-household transmission. There's a lot we're learning about transmission in the workplace. How much of this is about household structure and where people live and who they live with versus where they work and commute. I think sorting some of that stuff out would be very helpful. One of the things that we've seen is that if you look at who died in New York City or got very, very sick, a lot of older African Americans, right? But those people weren't out working. My sense is they were getting the infection from somebody at home who was out working. And so if that's right, and I just made that up, like I don't actually have good data behind that. That's my suspicion.
That's what the governor has said. Yeah.
What's that?
That's what the governor has.
Yeah, that's what the governor has suggested. And so if that's right, then, so first we should figure out, is that right? And if that's right, then there's a bunch of policy interventions you can make about how you protect workers and how you protect workers' families when they work at home. And so to me, understanding that would be really helpful. And then obviously also understanding how do we bolster hospitals and providers that disproportionately care for minority patients so that when they do get sick, the healthcare system is part of the solution and not part of the problem of disparities.
So I'm going to ask Ashish one more question, but if you have questions, please put them in on the chat and then I'll turn to the chat questions. And the question I wanted to ask is, you are really disappointed in the CDC and you've made that clear. Do you think that, I mean, first of all, any ideas what happened at the CDC? And then does it change the way you think about how we ought to organize public health, the management of public health in this country?
Yeah, so what's been striking is when I think about the really awesome people at the CDC, and they really are awesome, they're all still there. So it isn't like we've had this massive departure of expertise. And it isn't that these people have somehow forgotten their expertise. So clearly something is stifling their ability to do this. My best understanding is that the CDC has put in a set of policies that basically say you can't get ahead of the White House and you can't do anything that is like not cleared by the White House. And the CDC has been a much more sort of distributed organization than that, much more kind of working directly with states and giving advice directly with states and not having to get this kind of centralized clearance. And that's been a major policy change. I think it leads to two things. Either, well, certainly I think what's going to happen is states are going to decide that the CDC is an unreliable partner and are going to start building some of that capacity and technical expertise themselves. That may not be the worst thing in the world, but it's not the best thing in the world because you actually had an agency that had all of that and gave it very easily. So, but it is what it is. Second is I can imagine, depending a lot on what happens after the election, if you have a different leadership of the CDC and a different leadership at the White House that is more committed to a federal partnership that really helps states, as opposed to kind of leaving states on their own, then states may, as the pandemic goes on, decide, actually, this was a blip, it doesn't really count. I still think over the long run, the relationship between states and CDC has been altered in a way that I didn't expect would happen in my lifetime.
So I have a couple of questions from the group. One is about crisis communications. What aspects of crisis communications do you think we should be thinking about? What would you like to know more about? And can you elaborate on that point a little more?
Yeah, I think one of the things that's been done particularly poorly is, well, one is we've generally not been hearing much from the scientists. And when I think back to H1N1, Ebola, we heard a little bit from President Obama, but not much. It was largely Tom Frieden of the CDC, Tony Fauci. And it's different to hear from the scientists for two reasons. One is obviously scientists speak differently and they are generally much less polarizing. So when President Trump is giving the same piece of information that, let's say, Tony Fauci might, now Tony Fauci has become a little bit of a polarizing figure recently, which is really amazing to me. But you don't have to like or dislike Donald Trump. I mean, if you like or dislike Donald Trump, you can take that information very, very differently. If you heard it from Tony Fauci, who was generally pretty apolitical, you were much more receptive to that information. So the information and the delivery of that information, who's delivering it, really matters a lot. So I would have liked to have heard more from scientists. I think the second is there has been not enough communication about the uncertainties and the downsides of what's coming. And so this constant, we got it under control, we're doing plenty of tests, this disease is going to be gone very soon. At some point, it no longer resonates because the reality people are seeing in their lives differs from that. And so one of the things that, and I learned this a bit because I made some of these mistakes obviously at a very different level during the Ebola crisis, Whereas in an effort to try to reassure people, I probably overdid the reassurance. And we're seeing that in a massive way now, where people are saying crazy things that we just know to be not true. And it's actually not reassuring. I think people find reassurance from people being very open about uncertainty, and we're not seeing that in the same way. So there's an entire set of work I think that needs to be done to try to figure out how do we do this better, but also what do we do when the political leadership is not actually able to engage in crisis leadership effectively.
Thank you. So I have one last question for you, and then we'll let you go off on your day. And it's actually the connection between COVID and the research you've done beforehand, which is you talked about how the healthcare system itself might be failing African Americans because of the hospitals that they go to. And one of our participants wants to know whether there's also evidence that that African Americans are getting worse treatment even when they go to the better hospitals or to different hospitals. How would you think about this problem of disparities in healthcare treatment?
So there's a large literature on this kind of within versus between differences on disparities, right? Which is at the same institution, do they get differential care? And then how much of it is driven by just going to different institutions? And I've always sort of said overall, if I had to make a single judgment, it's about half and half. But the truth is, in certain areas, it's driven primarily by where you go. And in certain areas, there are differences in interpersonal stuff and interpersonal care that really where you do see gaps. I don't know how this plays out with COVID, to be perfectly honest. I don't know how much of it is. If I were a guessing person, I would say for COVID, it's much more driven by where people are going, but I just guessed. We don't have the empirical data, so we got to actually sort that out and really try to understand what's driving those differences.
Well, thank you so much, Ashish, for joining us for this webinar and for sharing your insights. And I look forward to reading your Twitter post tomorrow or this afternoon. Take care.
Thank you all for having me on.
Bye.
Bye-bye.
Take care.